and I'd like to welcome you all to our series called Prepare for Victory Virtual Medical Symposium Series. We created this program because we want to give you, no matter where you are in the world, the opportunity to hear the best information on genetic aortic conditions and other genetic conditions that overlap with Marfan from our professional advisory board and other leading medical experts on these conditions. I want to especially thank the Chu and Chan Foundation for making these webinars possible. Tonight, we especially welcome our friends with Stickler syndrome. Before we get to our presentation, I'd like to introduce Michael Weimer, the President and CEO of the Marfan Foundation, to welcome you and give a short intro.
Eileen, thanks very much. Good evening, everybody. Michael. It was great to see. Can you hear me? Can you hear me now?
Yes, you're on.
Yes.
Yes.
I thought you couldn't hear me. Anyhow, what I was saying, it's nice to see we had over 100 people sign up for this evening. We're very excited to have Rachel as a new member of our PAB. She joined us a year ago, almost. And, you know, eye issues are very important across a number of Marfan and related conditions. Also, we recently had the Stickler involved people join the foundation, and I've gotten to know Rick Bishop, who was on here this evening. I will be introducing him in a moment or two, but it's nice to have their group involved. And, you know, next year for annual conference in Chicago, we will probably or hope to or will be offering special programming around Stickler syndrome. Unfortunately, if you haven't seen the announcement, our annual conference in Boston has been canceled. You know, our motto has been to protect and inform since the onset of COVID-19. And it just got to the point that the what ifs were so many and so potentially harmful that we decided not to hold the conference this year. And I think it would be the first, I believe it'd be the first time in 36 years there has not been a Marfan Foundation annual conference. We're deeply disappointed. To me, it's like a family reunion. If you've never been to a conference, I hope you'll come to Chicago next July. You'll have an extraordinary time and meet some of the greatest physicians and scientists really in the world. So something to look forward to. Also, we're planning a big event on international scope. It will be a virtual event for late this summer into very early fall. That event will probably be announced in the probably the next few weeks. So we look forward to having you join us for our virtual summit. Watch for that announcement. And just to thank everybody for coming out. You know, we do what we do at the Marfan Foundation because of you. You know, that's our sole purpose, and we get up every day to try to make life healthier for individuals with Marfan and related conditions. And you're part of our family, so we really deeply appreciate that. With that said, I'm going to introduce Rick for a few brief words. Rick Bishop is with the Stickler Foundation. He's become a good friend. I love working with the Stickler folks, and so Rick, would you like to say hello?
I'm trying to allow him to talk here. So I think I did that. Rick, I'm going to try to say hello. There you go.
Can everyone hear me?
We hear you.
Good.
Well, thank you, Mike. I'd like to thank Mike and Eileen for this opportunity for the Stickler involved people to join your group. We are very excited about the potential of expanding our research and knowledge on Stickler syndrome and how it relates to related syndromes. Now, we started back in 1990. Pat Houchin and Bill Houchin actually started the group, and we started with, when I joined, I think I was number 4 in the group, and now we have over, I'm sure it's over 800 plus on our register. So we started locally in the United States. There was another group in United Kingdom that was already formed, and we've gotten in contact with individuals in the Netherlands, you know, even Spain, to name a few, in Mexico. So we're pretty much worldwide, even New Zealand. We got New Zealand here tonight, I heard. So in order to not delay this any further, I just want to thank Mike and the group for letting us join the Marfan Foundation. We're looking forward to the 2021 conference as well. So thanks a lot.
Rick, thank you. And if anybody wants to reach out to Stickler involved people, or Rick in particular, you can either drop him a note tonight, or you can reach out to Eileen and myself, and would be glad to help make things. So thank you for what you're doing, and I'm going to turn it back to Eileen.
Yeah, well, thank you, Michael, and thank you, Rick. And we'll put that contact information in the follow-up email for you all. So thank you. So as we move on, I want to just remind you, tonight's presentation is on eye issues in Marfan, Stickler syndrome, and other related conditions. If you have questions during the presentation, please type them in the Q&A box, which you will see on your screen. We will leave time at the end to answer questions. So as Michael said, we are fortunate to have an outstanding medical expert on our professional advisory board to address these issues tonight. Dr. Rachel Kuchtey is Associate Professor in the Department of Ophthalmology and Visual Sciences at Vanderbilt University. She joined the faculty of the Vanderbilt Eye Institute in 2005 after completing her ophthalmology residency and glaucoma fellowship training at the Cole Eye Institute of the Cleveland Clinic Foundation. She specializes in screening, diagnosis, and management of different forms of glaucoma. In addition to her clinical duties, she is the principal investigator of a glaucoma research laboratory funded by the National Eye Institute. So now we are going to try to give her the remote control. Let's see. Do you have it there?
Yes, I do. So
great.
I am trying to get my slides up. Now, can you see my slides?
Not yet. You need to pick that screen. You click share screen, the green button. And then you pick the screen that
I don't see this. I had it, and I don't know how I
move your mouse over the bar so you can see it.
I had it. I know I had it. Now I see it.
You see it?
Yep.
Great.
Now I'm going to do share.
There we go. There we go.
Use text.
Now you just need to go to slideshow from the beginning, and we'll hit go to slideshow and from the beginning, and then we will be set to go.
Excellent. Okay. Yeah. Thanks for giving me this opportunity, Eileen and Michael and Rick. It was nice to meet you virtually. And as Eileen mentioned, that I've been with Vanderbilt since 2005. My subspecialty is glaucoma. I'll go through this, and then you will see that why I have to deal with Marfan patients. So I appreciate this opportunity, not just helping. Hopefully, will be helpful to all the participants. It helps me to give me some sense of a normalcy. So this is really has been difficult. So this gives me, makes me happy to have this opportunity. Now, I was initially charged to talk about eye issues in Marfan syndrome. Later on, Eileen told me that, could you talk about the Stickler syndrome? I said, sure, I have a fair number of patients with this Stickler syndrome as well. So since they share many commonalities, so I will put those together. I started out with an eye, and since this is as I said, they share many common things. So here's a statement I have. Marfan patients could sustain all eye diseases as in general population, but specifically for Marfan patients, I broke that down to major problems and minor problems. I don't want to downplay the minor problems. So since some patients will think this is a major problem for them, but what I mean major problems and minor problems is some diseases, some conditions can be blinding and can be visually very significant. Some problems can be easily fixed by ophthalmologists. So the major problems include 4 conditions: dislocated lens. I would just use the terminology ectopia lentis. I think this is very familiar with everyone in this forum. That prevalence can be as high as 60%. Some reports even up to 70, even higher than 70% in Marfan population. Cataract is another major problem. You may say, what is a big deal, cataract? It is not a big deal. I am a cataract surgeon. I tell my patients that oftentimes I get asked, why do I get a cataract? I tell my patients, everyone gets cataract. You live long enough, you get visually significant cataract. We take care of those patients easily. The challenge part is for Marfan population is that you get a cataract much earlier, can be as earlier as 10, 12, 20 years, even 30 years earlier than the general population. We talked about this in detail just a little bit. The third issue is retina detachment. I would say 10% is a little bit underestimate, depending upon what study you're looking at, but it is a major problem. Glaucoma can be as high as 30%. This may be even a little bit underestimated number, simply because glaucoma can be difficult to detect. So those are the major problems. Minor ones include refractive errors. I say it's minor because oftentimes you just wear contact lenses, you wear glasses that can be easily corrected. No big deal, right? Non-invasive approach. Amblyopia, which is defined as a lazy eye. We talked about this just a little bit. Strabismus, the eyes wander, they're not straight. Iris hypoplasia and poor pupil dilation. This is more or less for the physicians. You don't take care of Marfan patients often enough. You forget about this, and that can cause trouble. For instance, when you do the cataract surgery, if you're not prepared, you're not aware of or not thinking of, those patients tend to have iris hypoplasia, their pupils don't dilate well. You're not prepared. You encounter the complications that can be bad thing. So it wouldn't hurt, even though this is not much for the patient education, but I think it's a good idea to keep that in mind. When you go see your doctor, you're gonna remind your doctors, be your own advocate. Look, I was told my pupils just don't dilate well. Be prepared if you need to do the cataract surgery. Okay, so those are the major problems and minor problems. Let's go over every one of those. Dislocated lens or ectopia lentis. This is a schematic of eye. I'll walk you through. I think, yeah, I do have can you see my cursor, my mouse? Eileen,
yes,
you're muted.
We see it. Yes, we see it.
Excellent. So I just wanted to make sure. So this is a schematic of eye. Just imagine I'll walk you through. So this is half. This is the front part, and the back part I chopped it off basically. So the yellow line is a cornea, which is clear. So that light goes through from the top, going through this dark hole, this aperture, and the dark hole is formed. There's a broken line here, and you see the orange part. This is the iris. Iris gives you the color. Some people have blue eyes. I have brown eyes. That's the color it's from. And go through this lens. Why the lens on the left, the right, they're different. I'll go over just a little bit. But nonetheless, this lens is supposed to be clear, okay? So the light go through the cornea, go through the aperture, which is a pupil, the dark hole, go through the clear lens, eventually reach the back part of the eye. That's how you see. Very simple. But I want you to take a look at this lens. You can see this. This lens is in a pretty precarious position. It's literally suspended in the middle of nowhere, just in the eye, in the eye cavity, suspended by and held by those stringy structures. those structures, they're called zonules. Those are almost like elastic bands. They can relax, they can get tensed up. When they are relaxed, the lens gets flatter, that's on the left side. This would allow you to focus the distance objects, so you can see far away. If you relax your zonules, and the lens becomes rounder, and this will get accommodated. You hear this accommodation of the eye that would allow you to read up close. So do me a favor, you can do this now. Look at the computer screen, look at it far away in your room. You're not even aware of this. You change the focal point in a millisecond. So that's thanks to those elastic bands, those zonules. They contract, they relax very easily without you even being aware of that. And they provide the structure stability to suspend the lens in the location. And guess what? Those elastic bands are mainly made of fibrillin 1, which is encoded by the gene FBN1. So now you got it. So you have the mutation in the FBN1 gene, and the zonules can be broken. They're not doing their job. Therefore, the lens can be dislocated. That's how you get a dislocated lens. Now, here is the real patient. There's two eyes. If the first eye, you can see this, and the blue eye on your left screen. And you see the dark hole, that's the aperture, that's the pupil. You don't see anything. And if you look at the top part, you don't see the zonules. You don't see the elastic bands because it's blocked by the iris, right? So you only see through the dark hole. But if you look at the right, the other eye, and you can see the flimsy, the stringy stuff. Those are the zonules. Why you're seeing this through the small hole, the aperture, because the lens is dislocated. The zonules are broken. So that happens in Marfan patients. That's ectopia lentis. The cataract. Now here is another patient of mine I want to show you. Said again that you have to be your own advocate. And this is a patient, and it's one, and this is the other eye. The first eye, you can see this. I'm sure you can appreciate this. This is again is the dark hole, the aperture, the pupil, and it's clear. But on the bottom part, you can appreciate. I have the blue arrow indicating there's a crescent shape, okay? That's because the lens is dislocated superiorly, moved upward. So that's why you have this empty space. At this point, those patients can have totally asymptomatic. They don't complain. And this, if you just do like a casual eye exam, you're not aware of this, and you can easily miss it. So you have to make sure that your physician's aware of this. And we encounter, at least I encounter those patients. The cardiologist, for instance, the internist send those patients to me, ask me to check the eyes, to provide this the finding. Do I see the ectopia lentis? That is actually one of the major criteria for diagnosing Marfan syndrome. And this eye is just way too obvious. And this is the other eye. You can see this. The lens is actually bisecting the aperture, the pupil. And you can imagine at this point, you get confused when the light goes through, not only just going through this portion, through this portion as well. So the light gets scattered on the back. So that becomes this, at this point, the patient can be very, very symptomatic. They do complain. There are ways to fix it, but you do have to be aware of the potential complications. Now on to cataract. This is your typical age-related cataract. As I said, everyone gets it. That's just a part of the normal aging change. Lens becomes cloudy. That's the definition of a cataract. What do? Can be easily taken care of. Actually, it's a very fun surgery. We do this. This is the most commonly performed eye surgery in our field. And you can see this, and this is the illustration how the surgery works. Again, this is partially just the front part, the part of the eye. The back is behind. Now, you make an incision in the clear cornea, which doesn't contain any blood vessels at all. The incision is so small. Right after the surgery, those patients, other than the fact those patients can see, and you don't see anything. There's no bleeding because cornea is clear. There's no blood vessel. You make an incision, you put instrument inside eye. After the pupil is dilated, remember, Marfan patients, they have a poorly dilated pupil. If the pupil doesn't dilate well, that alone can make the surgery difficult, okay? There are ways to take care of this, but your eye surgeon has to be aware of this. So if you can dilate the pupil well, and this would allow you to use this instrument to reach the lens. When you reach the cloudy lens, you literally break into small pieces. And this instrument has aspiration portal. So you basically break it down using the energy, ultrasound energy, suck it in to this same instrument and get the lens out. And some patients would ask me, say now when you remove my cataract, can I have it as a souvenir? I said, no, you don't. You don't want to have it. I'm gonna break down that baby and it just, you're not gonna deliver the whole baby out. When you have, this was the old way to do the surgery. We didn't have this instrument. We have to make a large incision, deliver the whole baby out, basically. You can imagine the surgery was a whole different way to perform. Now we don't have any souvenir for patients at all. After the cataract is removed, we use the same incision, putting another instrument, which is a delivery system. On the right is the artificial lens. You put artificial lens in the eye. It's just a piece of plastic. It's very soft. You can fold it up and put into this delivery system. When you get inside, when the lens gets inside the eye, because it's just very soft and gets unfolded on its own, gets suspended in this called a capsular bag, which is just wrapping off the lens. We call that capsule. So that's how the standard cataract is performed. Notice that those zonules on the left side, on the right side, they have to be stable. Even though this is a very simple procedure, but you are energy, the ultrasound, what have you, you are introducing a lot of trauma to the eye. If those zonules, those elastic bands, are already broken or they're not stable, you can encounter a lot of complications. If they're not doing the job, the whole bag just cannot be suspended there. You have nowhere to put this artificial lens. The artificial lens is important, and I tell my patients it's almost like wearing glasses inside your eye. Has a prescription. The prescription is determined based on the shape of your eyeballs, based on the curvature, how long your eyeballs are, how curved your eyeballs are. We actually do the measurements. And after the measurement, we calculate what kind of artificial light, what power of artificial to put inside the eye. So it's important to put artificial lens in the proper position, which is behind the pupil, you can see here. That's how the standard surgery is performed. As I mentioned, if zonules are not stable, you're not going to be able to hold the artificial lens in the proper position. You find ways to put the lens into different positions. For instance, here, this blue eye individual, I'm sure you can see this on the blue background. You can see there's an artificial lens. It's actually on top of the iris, on top of the blue part. And this one is, what do you call it? Hazel eye with some yellow specks there. And you can see that the artificial lens is on top of the iris. No big deal. You still can see well. You can get a 20/20 vision by using this type of lens. The trouble is that those lenses, they're supposed to be in the physiological position, which is behind the pupil, okay? You're clever. You're able to put the lens in front of the pupil, in front of the iris. Now the patients can see, but down the road, you need to make sure, be aware, potential complications can occur. because the lens is not in the artificial lens, is not in the physiological condition that can damage the cornea. We call that cornea decompensation. Decompensated enough, some patients would require cornea transplant. The flow of the fluid inside the eye can be blocked, the natural flow, and the pressure can go up. You get a glaucoma. So complications can occur if the lens is not put in the proper position. Ordinarily, these complications occur in the ordinary cataract cases as well. But typical patients, say if a patient is 5 years old, and that guy is going to be happy after I remove that very dense cataract, he's going to be very happy. And the complications may or may not occur in the immediate future, may occur 5 years, 10 years down the road. But that patient may or may not live that long enough to 95 years old. Marfan patients are different. They get a cataract at a much earlier age, and you absolutely need to be aware of those potential complications. Don't let those patients go. You need to watch those patients for the rest of their life. So that's a cataract surgery. Move on to detached retina. Here is, again, schematic of the eye. I want to just see if I can catch your attention. So I changed the orientation. Now the cornea is on the right side, okay? This is not a half eye anymore. This is entire eye. The light go through from the right side through the clear cornea, go through the pupil, the dark aperture, goes through the clear lens, gets focused on the back part of the eye, which is aligned by this very delicate tissue called the retina. Retina is a very intricate tissue, has multiple layers, multiple cell types. Those cells, they have to communicate with each other. Sometimes they hold hands together. Sometimes they use hands and feet, hold it together, and they communicate. And when they receive the signal, so here you have to remember, this is all photo signal, all light signal, right? Gets put into the retina. The retina has to, those cells, they have to convert to the electrical signal. It's very intricate, called the phototransduction pathway. Very interesting. Those cells have to do proper job. And one cell types is called the retinal ganglion cells. They have a very long feet. Those long feet, they form fibers, and those fibers get collected and form this optic nerve. So they send a signal through the optic nerve up and to your brain. That's how you see, okay? Retina is very delicate tissue. It's almost like a rice paper and can be easily broken by trauma, by, what have you, just ordinarily. Unfortunately, Marfan patients has a much higher rate of sustaining a tear of the retina. If you do that, you can get a detached retina. This is what we see when we shine the bright light. Here is your normal retina. And I'm sure you can appreciate that this is a different color. It's kind of like a peeling off from the back wall. At this point, the entire retina is not detached yet. Right in the middle, that's called a macular. I'm sure you hear patients get a macular degeneration. That is the physiological or anatomical location in the eye that gives you the sharpest vision. Now, the macular is still intact. So at that point, the patient is still okay, but you sure have some symptoms. This is what you see. If you have a tear or tears, or you have detached retina, think three things. This is every ophthalmologist knows when someone comes into your office, have some kind of vague complaint, you always, we call it RD precaution. You tell the patients you need to take a precaution. RD stands for retina detachment. Those are three signs, floaters, and the dark spots, those are the floaters. We all see floaters. Again, part of the aging change. I see floaters, once in a while. Some patients say, I try to catch it, and then it goes away, and it's like a fly flying from the face. Normal If you have the floaters caused by retina tear or tears, those floaters, I call them bug storm. They are there. They're always there. They are flying around, and they doesn't matter in the dark or in the bright condition. You see them all the time. So that's number one. Number two, flashing lights. Few sparkles here, there. We all see that. Sometimes you just put them, pressure. You sleep in a very odd position. You wake up and you have some flashing lights. You're stimulating your retina. Once in a while, everyone sees that. But persistent flashing lights, sparkles always there. Doesn't matter in the dark, doesn't matter in the dark. That's the second sign of a detached retina. The last sign is this curtain. A curtain, this one is on the left side. I tell my patient, doesn't matter. You don't move your head. You look at it straight ahead, and you don't move your eyes. And you can distinctly tell there's a curtain on my left side. I just don't see it. There's a curtain coming down from the top. So floaters, flashing lights, and a curtain. Those are the three signs. You need to warn your doctor. Any of one of those occurs, 3 in the morning, you need to call, and that needs to be fixed on an urgent basis. Because that can be easily fixed. Anything that you want to do at early stage, you will have better outcome. Too late, even though you can get the retina attached anatomically, you can get complications. Glaucoma actually is one of the complications from detached retina. This is a real patient of mine, has Marfan syndrome. You can see on the bottom part, there's a little crescent shape, empty space. The lens is dislocated superiorly, moved upward, but that patient has no symptoms whatsoever. Come into the routine eye exam, and here is what we caught, a little bit of hemorrhage there, not in the macular. So that patient has no symptoms, just, routine eye exam. So it's important to keep your routine eye exam appointment. And we catch this, we see this. That's an indication there's a hole in the retina, and we have to fix it. So that my retina guy fixed this, and here is how that looks after the surgery. You have some scar, you can spare some retina, so you don't have a problem. Right in the middle, the macula is still okay, so that patient has pretty good outcome. Lost follow-up. Years later, comes back with a new hemorrhage. And what do you see here? Now it's right in the middle. It's much bigger. Now this is how this patient sees. If you don't have a detached retina, those two boys, you can clearly see their faces and everything, the balls. But if you have a detached retina, even though anatomically you can put the retina back in the good position, you lose the communication. Those cells just don't survive well. They can survive, but they don't necessarily do their good job. So now you get this called a central scotoma, meaning there's a dark spot right in the middle. At that point, you can be very symptomatic. Okay, so get the routine eyes done. And again, this is multidisciplinary approach. And I take care of those patients oftentimes at a very advanced stage, because oftentimes glaucoma is complications. It's a complication of other conditions. And sometimes it's not uncommon. Actually, someone has an eye problem. 3 eye surgeons go into the operating room at the same time. Everyone works in a different place. I get a cataract out. I take care of the glaucoma. My retina guy fixed the retina. The cornea person takes care of the cornea at the same time. So it really requires a multidisciplinary approach. Now, the last major thing is the glaucoma. As I mentioned, I am a glaucoma specialist. So I see those patients, oftentimes they are quite far into the disease from the complications. Now, it's not uncommon for no glaucoma. We call that primary glaucoma, meaning it's not the secondary to detached retina, not secondary to dislocated lens. We call that primary glaucoma. They actually, the rate, the prevalence is much higher than general population. So you don't think that, oh, my retina is fine, I won't get I won't get a glaucoma. Be aware that you need to remind your doctor that the glaucoma prevalence is higher than general population, even though I'm young, and you better check, make sure that I don't get glaucoma. So what exactly is glaucoma? By definition, glaucoma is nerve damage, is optic nerve damage. Again, this is a scope eye, this time turned 180 degrees, okay? The cornea left side, light go through the cornea, clear lens, go through the pupil, clear lens, and it gets focused on that part of the eye. The ganglion cells, remember they have long feet, they form those cables and they get wrapped around, they form the optic nerve, sending the signal, the electrical signal, back all the way to the visual cortex. So this nerve is really important. It is, once it's damaged, unfortunately, we have no way to fix the damage. The goal for me is to catch those patients at early stage and prevent it from getting worse, okay? Now, the cables is so important, and oftentimes I tell my patients, you're not just using your eye to see, you're actually using your brain to see. The eye is just a vehicle receiving the light signal. The signal has to be transmitted through the optic nerve to your brain, okay? So the nerve damage is really critical, and this is actually priority for National Eye Institute, that we need to preserve the nerve. How do you get the nerve damage? In general population, there are many theories. We call them multifactorial disease. I'll just list the three. Unfortunately, all three can occur fairly commonly in glaucoma, in Marfan population. Number one is pressure. Pressure inside the eye is too high, intuitively, that can directly damage the optic nerve. Okay, that's called the pressure etiology. Second one is vascular etiology. You can see this, the optic nerve, the red color actually here is the blood vessels. Really needs, that has a very high metabolic rate, really needs a lot of nutrients, oxygen, and those blood vessels, they have to properly supply the oxygen, the nutrients, and get the junk, the waste out of the optic nerve. And we know the Marfan patients do have some vascular etiology, so that can affect the optic regardless if the pressure is normal or not. Last thing, this is blow up, the close up of the optic nerve. And this band is called lamina crebosa. That is actually part of the connective tissue. Now, we know Marfan disease falls in the bigger category called connective tissue disease. So if you can imagine, and that connective is not stable, those cables, fibers, going through that supporting structure, they're not supported properly. Doesn't matter the pressure is high or low, doesn't matter how good your blood supply is, you have a strong foundation to support those fibers, you can get a nerve damage. We call that biomechanical theory. So unfortunately, as I said, Marfan patients can have all etiologies at play at time. When you get a nerve damage, this is what you see. This is called condition. This is a pretty advanced stage. Now you can see, you still can see those two boys, the faces, but part of the balls, part of the periphery background just faded out. So that's typical symptoms. At a very advanced stage, those patients will complain. Now we can map that using what's called the visual field testing. I'll walk you through, okay? And this one also illustrates the nature of glaucoma. Unfortunately, the glaucoma is, as I said, once the nerve is damaged, I cannot reverse it. My goal is to slow it down, slow down the progression. If you don't treat those patients aggressively, by definition, glaucoma is a progressive disease. Shows in this visual field testing, okay? I don't know how many people of you have done this visual field. Basically, you put your head in this bowl. When you see the lights, those lights have different sizes, they have different intensity based on that. And when you see that, you click the button and we map it, convert into this, called the visual field testing. And you can see this is the left eye. How do I know it's the left eye? There's a black spot, right? That is actually it's a blind spot. That's normal. If when you do the test, you don't show this in the printout, I don't see that black spot. I know you didn't do well. You're just trying to get over with that test. So we do have the quality control. So this is normal to see that black spot. But other than this black spot, by and large, this is a very good looking visual field and nothing to worry at this point, okay? This patient has, we call the pre-parametric glaucoma, meaning that the nerve appears damaged by the exam, but the patient, this is what the patient sees, doesn't have complaint whatsoever. So it's not visually significant. You would like to catch those patients at this stage and stop it, or at least to slow down, and then the patient won't sustain the blindness. Now, if you don't do that, inevitably, it's going to progress. And this is A to B at this point. You can see other than this black spot, you see some other black spots. This is on the right side. I said that this is the left eye. This is what you see, okay? You can test this yourself, as a matter of fact. This is nasal, on the nasal aspect. We call that nasal step. And here you have some superior defect. At this point, you have no symptom. You're not going to tell me, look, I got a nasal step, and you're not complaining. You're not going to complain at this stage, okay? This has been shown, studies after studies. Now, if you don't treat this patient, it's going to continue to progress to this C. At that point, not only there's a nasal step, there's a superior defect, there's an inferior defect. Believe it or not, even at this stage, it's moderate stage by definition of a visual field defect. Those are patients don't necessarily have any symptoms. So they can be left alone if they don't come to the eye doctors. We're not going to catch those patients. So if we don't catch those patients, you will progress to this stage. At that point, you only have a little bit of tunnel vision. The superiorly, inferiorly all turns darker. The darker spot is denser and is bigger. At this stage, D, that is by, even though you still can see 20/20 through this right in the middle, okay? You have a 20/20 vision, but by WHO definition, this eye can be legally blind because of this profound visual field deficit. So that's glaucoma. That's what we see. And this is what you see, the tunnel vision. And that at that point, you are truly symptomatic. Now, some minor issues. This is called a refractive error. So I'm going to show you just myopia. This is a normal eye. Again, the light now going through from the right side, reach to form the sharp focal point on the back part of the eye. That's how normally you see. In Marfan patients, the eyeballs tend to be bigger and longer, and the light has a hard time to reach to the retina, form the sharp focal point. So that's why you cannot see far away. And this is actually, it's very common. It's almost pandemic, especially in Asian population. The prevalence of myopia is very high and it can be corrected. Majority of patients have a somewhat low grade myopia, meaning the prescription say -1, -2, less than -3. You can use contact lenses, put a contact lens on top of the cornea, or just wear glasses, force the light be focused on the retina. So it can be properly corrected. It's much higher rate in Marfan patients have myopia. Astigmatism It's again, ordinarily, no big deal. Somehow, I get this quite often. My patients, they tell me, oh, I got this horrible condition called astigmatism. It's just a very common condition. And that by definition is that when the light goes through from the left side, when they get to the retina, rather than form a very sharp focal point, gets scattered all along the retina. You still can see, you just don't see sharply. This is what it shows, this is big E, right? Rather than the sharp arms, legs of the big E, and you see this fuzzy, shadowy appearance of the big E. It doesn't matter if those patients, they complain, they tell you that, I can see the roadside, I just don't see well. I'm so close to roadside, I still cannot see well. Some of my friends, they really have to get close to see clearly. When I get very close, I still don't see well. It's because of astigmatism. That's actually very common. It can be easily corrected with contact lenses, with glasses. That's in general population, okay? Marfan patients is a little bit difficult simply because this dislocated lens. If it's just called a cornea astigmatism, easy to do. Contact lenses, glasses, the cornea, and you probably would hear this from your doctor, that if you look at the cornea on the left side, and that is, we use the terminology like a basketball, meaning those two meridians, they have equal distance. If rather than being a basketball, now you have a football, it's oval shape. This meridian is a bit longer than this one. That's called astigmatism. Again, can be easily corrected with glasses. Marfan patients, the astigmatism is not just caused by cornea. You have this called lenticular astigmatism. And you can see this, light goes through this portion, light goes through this portion as well. You get really confused. At this point, even though the lens is still clear, there's no cataract at all, there is indication that you need to remove the lens so you can have those patients see better. Now, amblyopia, meaning it's just the lazy eye. This occurs in the young patient population. So there's a tiny window that, not a tiny, it's about 6-7 years. You need to catch that. If you don't see with one eye see well, your brain will never develop. And that's just basically, you need to be aware of this. Lazy eye can cause strabismus, and even older adults, one eye doesn't see well. Eventually your brain will give up, but the muscles is just not gonna work well anymore. So you can see the left eye wanders out. So those are the minor problems. Now, just last a few minutes, I'm gonna talk about Stickler's syndrome. You can see this, I really copied this statement. I just changed the word from Marfan to Stickler. And you can see all eye conditions in Stickler patients as what we see in general population. But again, some major issues similar to Marfan patients, but some particular things I need you to be aware of. Myopia, I mentioned that. Marfan patients, even general population, the prevalence is so high. You wear -2, -3 prescription glasses, contact lenses. Stickler patients, the prescription is very high, can be very high. It's called high myopia. The prescription, sometimes you can see -18, -24. It's much severe. That when it's that severe, that can cause a whole host of other conditions by just being nearsighted. Retinal detachment, the rate is much higher than Marfan patients, can be as high as half of the patients, 50% of patients. Cataract is very similar to Marfan patients, fairly high prevalence, again, early onset, much earlier than the general population. Glaucoma is not as bad as Marfan patients, but it's a blinding disease if you need to catch this early. I think this 10% is underestimated. Research is behind Marfan research, and this is a fairly recent paper just published a couple of weeks ago. So I quote here their conclusion. This is a meta-analysis using all the literature. We look at all the published data. The conclusion is that ocular manifestations are common in Stickler patients, but the comparison between studies was difficult because of the inconsistencies in diagnostic and inclusion criteria by different studies. Sight-threatening complications such as retinal detachments are common, but although prophylactic therapy, oftentimes cryo treatment or laser treatment, it's reported to be effective only in retrospective studies. Evidence from randomized clinical trials is missing. So we don't have a clear answer to tell patients, look, this is the clinical trial. We know the data. You kind of have to discuss with your individual eye doctor, use his or her own judgment to make a recommendation. Should you have prophylactic treatment to prevent detached retina? So the goal of the management for the patients is to maintain the equal vision, excellent vision, maintain the straight eyes, control glaucoma, control detached retina. And remember, this is a genetic disease. You need to inform the patients. When the patient wants to have their own family, you need to tell them this is the risk you have to take. And the key, again, be aware of those potential conditions and be your own advocate and be informed. I think we covered a lot, and I'm sure there are questions, and if I cannot answer now, and I have my email address here, feel free to shoot me an email, and anyone wants to jump in. Eileen, I think I'm gonna turn to you, and if however you want me to handle this.
Great. So I think my screen is now up there. You see my screen. So if you're up to questions and answers, great. So thank you so much. That was really incredible. And I know we're a little bit long, but we're definitely going to stay on, answer the questions that we have here in the box. So I'm going to go to a short one first so I can read the oh my gosh, you guys put these very long questions in here. So let me go with a quick one so I can read the other ones, because I was absolutely listening to this presentation, not reading the questions while you were typing. So the question is, Marfan strabismus, does this need correcting in many cases? Carrie says that she's a 10-year-old son with 19-degree turn, not sure where to go with him.
I listed as a minor problem. For some patients, this could be just cosmetic. She said, that can be. Go on, Eileen.
Okay, no, you go ahead. Go ahead, I'm sorry, I didn't mean to interrupt you.
So what I mean is that this is a discussion between the family and the physician. If it's just cosmetic, actually this can be very easily fixed. 10 years old, I'm not so sure if amblyopia or lazy eye has set in. It's late. If it truly that eye is lazy, you probably already missed a window opportunity to correct it. The way to correct it is to patch the good eye, to force the lazy eye to work. 10 years old, you are really late for that. So we're talking about the cosmetic issue. This can be very easily fixed by the pediatric ophthalmologist. Again, as I mentioned, that this is a multidisciplinary approach. You have to have the pediatric ophthalmologist who doesn't do anything but the muscle surgery to take care of your son.
Great, thank you. In general, is there a time of life that Marfan patients experience ectopia lentis? When they're young, middle-aged, or is it across the board?
Well, I have seen whole spectrum. I have, do I have infants? I don't think I have seen the infants, but I have seen the very young toddlers with the dislocated lens. And I have seen the very old folks, whole spectrum. There are some studies called the phenotype-genotype correlation study. The answer is still not that clear. Part of it is that the prevalence is not that high. It's not like a glaucoma. You gather thousands of patients. you can get some statistical analysis. This is just not so clear. There are certain mutations tend to give you dislocated lens. So the genetic testing can be powerful that you have to discuss with your doctor.
Okay, great, thank you. Is there also a connection between Marfan syndrome and cornea presentation?
The cornea presentation.
Yes,
cornea. Cornea, yes. There are issues. I didn't even bother to list it. This is mainly for your physicians to be aware. The cornea, some studies have shown they tend to be flatter rather than just we're talking about the curvature. They can be thinner. If the cornea is thinner than average patients, when you do the eye pressure check, that can mislead the number. So that's something that if the pressure, say the normal pressure is, the average pressure is anywhere from 11 to 21, your pressure is 18, is within the normal range. Just because your cornea is much thinner than average patients, that 18 is misleading. That can mislead the diagnosis of glaucoma. So yes, I think it's a good point. I'm glad you mentioned this, as a matter of fact. The cornea tends to be thinner, but doesn't have the higher risk. Say it's like Ehlers-Danlos patients, they have to call it brittle cornea. They don't necessarily break easily, but does have the thinner cornea than average patients.
Great, thank you. For somebody with Stickler, his retina surgeon placed a small hole at the bottom of his iris. Is this useful to prevent glaucoma?
Yes. Depending upon how the retina surgery is performed, sometimes you have to put a silicone oil in the eye. You have to put a gas bubble in the eye, put a fluid in the eye to maintain the position of the retina. If the gas bubble, the fluid in the eye, the silicone oil in the eye can be trapped behind the eye, that can cause a very severe glaucoma. So we do this called iridectomy, meaning it's truly is a hole. You're basically creating another pathway for the fluid to go through.
Okay, thank you. Can you talk about scleral buckle? Have you seen young patients have to get a second buckle later in life?
Yes. Scleral buckle is one of the ways to fix the detached retina. Many ways to fix the retina. If it's early stage, we call that prophylactic treatment. That is, can be done by the cryotherapy, can be done by the laser. You basically just seal off the hole. But if the retina is already detached, you really have to physically put things together. The way to do this, you put a silicone band around the eyeball. That's called the scleral buckle. It's really just like it is a buckle basically, for the lack of a better description. You sustain the retina in a good position. Another way to do this is called a vitrectomy. That is to put an instrument, a light pipe inside the eye. You seal the retina, put the retina into the position. Different ways to do this depending upon where the location of the tear, how severe the detachment is. That is the retina specialist. I cannot do this. I can diagnose someone with a detached retina, but I cannot do this. You have to have a proper retina fellowship trained physician to take care of this. Sometimes the buckle can be removed. Sometimes the buckle has to be removed. Sometimes you get a secondary detached retina. Buckle has to be reinforced. So it's not uncommon. You have to deal with the buckle later on.
Okay, great, thank you. If you had secondary ocular implants and the lens moves after 10 years or so, should you fix it or leave it?
Depending upon what the symptoms you have, if it doesn't bother you, you still can see clearly, and your brain can adapt to that easily, and it's not causing any trouble. It's the secondary lens can get dislocated in the wrong place, and that can clog up the drainage system. That can decompensate the cornea. That needs to be replaced. If it's not causing trouble and you can be safely watched, you have to remember any intervention. So I made it sound very simple, eye surgery. Yes, it is a surgery. We're not opening the heart. We're doing the eye surgery. They're simple, but if you can avoid the surgery, you'll be better off. For Marfan patients, I tell my patients, less is more. Try to avoid the surgery if you can. But, if it's needed, then get a skilled surgeon to take care of you.
Okay, we're going to do a couple more. Maybe we can do a couple. Maybe these might be short answers, I hope. What does the term eye migraine mean, and why does it occur?
That's $1 million question called ocular migraine. That's not necessarily specific to Marfan patients. My son actually has this condition. We actually call it ocular migraine without headaches. We don't know. We think it's because of spasming of the blood vessels in your head. And most of the time, it's like a clock that you have 30 minutes and goes away. And majority patients actually have no headaches whatsoever. It doesn't cause any trouble at all. Too frequent, and you need to alert your doctor. Maybe the indication there is a tumor compressing the blood vessels, but that is rarely seen. Most of the time, you're just reassuring to the patient. We don't even go through any imaging test whatsoever.
Okay, and we'll do one more, and then we're going to, and then we'll do the rest of these afterwards. Then we have a few more pieces after these questions. But the last question we'll do, somebody with Marfan syndrome has myopic degeneration caused by severe elongation of the eye. Do you have any new treatments to preserve his vision?
Difficult. Yes, we do have a new treatment. When the macular degeneration sets in, it is very similar to the bread and butter age-related macular degeneration. That's called AMD. That's the very common condition in old folks. But unfortunately, if you have a very elongated eye, and like -18, -20 correction, and like Stickler patients, that's the complication you can have even as young adult, 20 years old, you get macular degeneration. I give you an example, I've been in practice for over 15 years. At the beginning of my career, you tell the patient, sorry, sir, you got a macular degeneration. We have no treatment at all. Now we do. The myopic macular degeneration, the treatment is very similar to age-related macular degeneration. We can do the injection, we can do surgery, we can do laser. So it's treatable, but it is a tough condition.
Great, thank you. That was an excellent question for whoever asked that question. Thank you, Dr. Kuchtey. Before we finish up here and before Michael says a few extra words at the end, I just wanted to remind everybody about Backpack Health, which is a way to keep track of all your, it's an app that you can download. It's a way to keep track of all your medical records, your families. You can keep track of all your eye issues, along with every other system that you are involved with. You can also join the Marfan and Related Conditions International Patient Registry, which will help doctors answer questions in the future, whether it's about anything from heart to eyes to pregnancy. And you can join, go to our website, and you'll see the little that little icon down there. You'll find that on our website, and you can click on that and join the registry. We're at about 1,400 and something people. We're trying to get to 2020 by June. So we'd love you to join that. I also want to remind you about our next webinar that we have next week. It's part of our empowerment series, which is not medical, but it's quality of life. And this is going to be on caregiver support for taking care when you're taking care of other people and you need support. It's going to be presented by Jamie Barnhart, who is a Marfan mom and also is the founder of Aortic Hope. And that is May 13th at 8 o'clock. So the link to register is on our website, and I'll send that along in the follow-up as well. Our virtual Walk for Victory, actually our second one, is going to be on Saturday, June 6th, 1 o'clock Eastern, featuring an online party with DJ Willie Wow. You can register, you can have a team. It's all I can say is it was a lot of fun. We did it a couple weeks ago, and we hope you can all connect there. You'll get to see everybody. It's a webinar kind of format, and so, or meeting formats on Zoom. Everybody's doing Zoom parties now, right? So I'll be able to see DJ Willie, see everybody else in our community, and I promise it'll be a lot of fun. And as I mentioned about all these questions, Jan, our nurse, who's the head of our help center, she will help answer these, and we'll reach out to Dr. Kuchtey if she needs additional assistance for that. You can also ask Jan questions at any time, submit them through our website, and there is the URL for that, marfan.org/ask. And as a reminder, all of our coronavirus information is at marfan.org/COVID-19. So we've had a lot of information. I think we have another statement coming out next week, possibly, or the next few days. So, stay tuned on that. We'll keep you posted on anything related to our community and COVID. And then finally, if you'd like to get involved, we have Volunteers for Victory, ways to get involved. Social media is a big one now since we're not doing things in person, but we'd love to see you in person in the future. But in the meantime, there are plenty of ways to get involved, and you can do that through our website and reach our staff. So before we say goodnight and all our thank yous, Michael, do you want to say a few final words?
I would love to. Rachel, thank you. I've been to, I think, most of these webinars over a long period of time, and this was just terrific. I'm walking away here tonight just so thankful that you're involved with the foundation, and so thankful that you're seeing members of our community. And I got to tell you something. If I ever have a question about glaucoma or need to see a doctor, I'll be on my way to Vanderbilt for sure. From the bottom of my heart, I think on behalf of everybody on this call, you were just amazing.
Can I say something, follow that, Michael?
Of course.
My thanks to you guys and to all the listeners there. As I said, this really gives me the sense of normalcy, and we are back to business. We have a 50% of capacity now, and I'm just so happy to be with patients. It really gives me sense of a purpose. So you guys actually made my day. I really appreciate this opportunity.
Well, thank you so much, and to everybody who is who has logged in, thank you for joining us tonight. We do want your feedback, and we will be emailing you with some follow-up points from tonight and links to some of the materials that Dr. Kuchtey mentioned, and we're here for you, and as she said, she is as well. So thank you all, and have a good night.
Good night.
Good night, everybody.